Yeah, I'm very delighted to be here and to share with you findings from the program of research I've led and I'm still leading. I'm a member of a community of practice in our Bristol, South Gloucestershire and North Somerset Integrated Care Board. And I know that there are quite a few communities of practice around the UK working on the same problem, addressing the same issue of trauma and trauma-informed approaches or trauma-informed care. And these events where we can learn from each other and share knowledge and experiences is one of the recommendations we made at the end of the study. And I'm so glad that it is working on the ground because of people like you. To add to my short biography, I probably would like to disclose and position myself also as a survivor of adverse childhood experiences and intimate partner violence. And I think that it's difficult to separate our individual personal lived experiences from our professional roles, but they definitely impact these lived experiences definitely influence our choices about career, what we're doing, how we're doing things, what topics we choose for our research projects. Yeah, so it's not possible to separate. Let me start sharing the presentation. My understanding that the plan is for me to talk, then there is time for questions. And I would really like it to become a discussion rather than a didactic lecturing meeting. Yeah, so am I understanding, Angela, that people can put their questions in the chat while I am talking, and then there will be time, allocated time at the end for questions and answers. Exactly. There will also be polls where we will ask you questions, and Angela did some wizardry, and we will do voting in Menti to get some feedback from you. Okay, so the topic for today's talk is understanding trauma-informed organizational change, and I will be talking about evidence from research. And I thought that we might start with watching a 4-minute video which we produced at the end of the program of research I'm talking about today, which summarizes briefly with illustrations of why we started this study and what we found. And then after watching this video animation, I will talk in more details through the process, through the findings and practical implications. Okay, and now to tailor my talk, the explanation and elaboration of what you've just seen, it would be nice to understand who is in the audience. And we prepared the poll, and Angela can share it, that you can indicate your main role. There is a Menti link in the chat.
I think we've reached almost the total number of people in the room. Should I go on to the next, or I'll give people a minute more?
Yeah, so I'm pleased to see that we have a varied distribution of roles with 11 managers, 8 practitioners, 3 people identified as other, 2 students and 1 policymaker, 12 managers now. I identify myself as a researcher, as my main role is a researcher at the moment. So yeah, lovely distribution. So I will adjust my presentation accordingly. So the next poll asks you to score the level of confidence with which you discuss research evidence for a trauma-informed approach in healthcare organization. Okay, it was a perfect distribution, and statistics is called normal distribution. Fantastic. So we will repeat this confidence checker at the end, just for ourselves to see whether the intended learning outcomes for this session has been achieved, which is share the knowledge with you. Okay, let me share my screen now. We all know that psychological trauma can be caused by various events and life circumstances like childhood adversities, individual or collective traumatic events, complex trauma like domestic violence and abuse, or systemic social injustice. From people with lived experience, from research, from clinical practice, we know that many service users and service providers can have experienced trauma in their lives, and all service providers work with people affected by trauma. Later, I will be using terms patients and staff because our research program was conducted in primary care and community mental health care. So we worked with patients and staff, but everything which I will be talking about is relevant to any human service working with people: healthcare, social care, education, police, prisons, any service working with people. From epidemiological studies, we know that individuals and families affected by trauma seek support from healthcare and other services for the physical, psychological, and socioeconomic consequences of these experiences, that these impacts accumulate through the life course from childhood to adulthood. We also know that if the high rate of trauma and its widespread impacts are not recognized, services can fail to engage service users in treatment and can re-traumatize both patients and staff. A trauma-informed approach is an organizational change program which can be implemented in any service working with people. A trauma-informed approach incorporates knowledge about universal prevalence and impacts of trauma into policies and practices, environments and relationships to promote physical and emotional safety for patients and staff. It is show word cloud again. Someone asks me. I can see it in the chat box.
We will be sharing the slides after, so if you want to take a closer look afterwards, that's also fine.
Thank you. So there is an assumption or hypothesis that trauma-informed organizational change programs can improve experiences and outcomes for service users and staff and can prevent re-traumatization in services. And as a result, many UK policies and guidelines recommend implementing a trauma-informed approach across healthcare and other systems. However, despite this concept of a trauma-informed approach being around since the early 2000s, the evidence base for its effectiveness and acceptability is still in development globally. And we know that evidence to inform policy and practice come from three main sources: from research, from best practice, and from people with lived experience. And today I will share with you the current research evidence to inform implementation of a trauma-informed approach in your organizations. We conducted a program of research with the overarching aim, the TAPCARE study, which is an abbreviation for trauma-informed approaches in primary care and community mental health care. And this program of research included a systematic review, which answered the research question: how effective and cost-effective are trauma-informed organizational change programs in adult primary care and community mental health care services? And the second component was a policy review study, which answers the question: how trauma-informed approach is understood and implemented in the UK, and how it is presented in health policies. When we started the study, we quickly realized that people use different terms and interpretations of a trauma-informed approach. Some people attach trauma-informed adjective to a standalone clinical practice, for example, a trauma-informed medical history taking or a trauma-informed physical examination, while other people apply the trauma-informed approach to organization or a wider system. And this latter approach involves changes in organizational structures and resources and culture, so-called organizational domain, which is followed by trauma-informed changes in clinical practices, so-called clinical domain. So the top care study was interested in a trauma-informed approach at the organization level, the second version or model. This is a word cloud from the analysis of policy documents, illustrating different terminology used by the authors. You can see people call it a trauma-informed approach, trauma-informed care, trauma and violence-informed care, trauma-informed service, trauma-informed system, and so on. However, despite using slightly different terminology, when we compared the 8 most cited frameworks for a trauma-informed approach at the organization level, we found that they all provided rather a high-level guidance on how to do a trauma-informed transformation, rather than prescribed what organizations should actually do. And this kind of conceptual fluidity and lack of direct instructions and guidance, I think, contributes towards sometimes misunderstanding or misinterpretation of what a trauma-informed approach is. And this word is applied to anything and everything which is linked toward trauma. So all the frameworks we analyzed is generally aligned with the guidance from the US Substance Abuse and Mental Health Services Administration. A trauma-informed approach starts from the assumption that every patient and member of staff have the potential of having been affected by trauma. And through realizing and recognizing these experiences and impacts, we can respond by fully integrating knowledge about trauma into policies, procedures, and practices. And through this way of service provision, we can actively prevent re-traumatization in services and improve experiences and outcomes for all. You can see it's very high level formulation and conceptualization. I mean, what does it actually mean? And the process of becoming a trauma-informed organization is guided by the key principles of safety, trust, peer support, collaboration, empowerment, and cultural sensitivity. And you probably saw other frameworks where there are 7 principles or 5, but they are all in principle, in general, aligned with this generic principles. And these key assumptions and principles should be applied across the 10 implementation domains. And these are governance and leadership, policy, physical environment, engagement of people with lived experience in the transformation process, cross-sector collaboration, diagnosis and treatment for trauma, training and workforce development, progress monitoring and quality assurance, financing and evaluation. Again, very broad implementation domains. The process of becoming a trauma-informed organization was described as a transformation journey rather than a one-off activity. And these changes were happening alongside this journey through disruption of usual practices and through cycles of reflective learning and reflective practice. Despite extensive searches, our systematic review found only 6 studies in primary care and community mental health care organizations, 3 from the US and 1 each from the UK, Australia, and Canada. And in these studies, trauma-informed organizational change interventions were applied in public primary care clinics that served populations with high rates of trauma, and in public and third sector specialist organizations that provided services to women with a history of interpersonal violence. We found that healthcare organizations applied the key assumptions and principles across varied implementation domains and through different components. And this resulted in developing bespoke trauma-informed approaches that were contextually tailored to each organizational needs, abilities, and preferences. So although they use kind of similar building blocks, they each constructed and designed their own service-specific, organization-specific trauma-informed approach. I'll give you examples of what they did within each implementation domain that you can apply these generic terms to everyday practice. Like, for example, let's take the governance and leadership domain. It was reported in 5 models. The 6 studies which we included, they evaluated 8 different models in 8 organizations. So the governance and leadership, how they did it. For example, in one study, they described engagement of clinical, administrative leaders, managers in consultations with clinicians and with other staff to conduct local needs assessment, to select 3 to 5 priorities, and to develop a plan for addressing each priority to make their organization more trauma-informed. In another model, which was a quality improvement project, they again set up the quality improvement team, which included directors from each service, the quality improvement coordinator, and the senior clinician. In another organization, there was a steering committee involving all leadership, and the monthly meetings were open for all staff to attend. And these high-level leadership structures led and strategized the trauma-informed changes in each organization. The written policies and procedures domain was reported in 3 models, and examples include harm reduction policies and practices for supporting patients with substance use issues in one case, or system-wide quality improvement priorities, which were aligned with the state and national performance metrics for treating depression and alcohol and substance use. So they developed team-based workflow, standardized processes and protocols for supporting people with experiences of depression, alcohol, substance abuse, and violence. And another example was a mission statement from the organization in which they acknowledge that they are providing a social model of care, and a trauma-informed approach is their mission. This is how they deliver services. 7 models made changes in the physical environments to make them safe for patients and for staff. And these changes ranged from women-only spaces and activities with provision of childcare, through redesigning waiting rooms and offices, to extending opening time and consultation length. The engagement of people with lived experience domain was reported in 6 studies, and again, each organization involved people with lived experience through different activities. In one organization, they used service users and healthcare professionals with lived experience to help them to design and or deliver trauma-specific interventions on site. In another organization, they hired and integrated an indigenous elder to participate in clinical activities. Several organizations set up patient advisory boards or a steering committee in which they invited people with lived experience to participate. Cross-sectoral collaboration was reported in 6 models, and again, varied by organizations what they actually did. but several organizations developed new working relationships with the local community or community organizations, non-profit organizations, and other services. Some formalized their partnerships through signing agreements and other formal documentation. All models integrated trauma and violence-informed approaches in diagnostic and treatment processes and practices. 5 models included screening for history of trauma and/or mental health conditions. All models provided on-site or external trauma-informed or trauma-specific psychological and social interventions, ranging from chronic pain clinic through trauma-sensitive gynecological care to CBT groups. Of 8 models, 5 provided training for all staff and trauma-informed supervision. 2 trained individual providers, 3 had trauma champions, and 4 provided self-care and well-being activities for staff. The content, format, and duration of the training varied, and the common features were delivery by external experts, tailoring to the organizational context and patient population, and booster sessions. And similarly, tailored self-care activities included mindfulness sessions, well-being days, and trauma-informed supervision. Varied activities to monitor progress and quality were reported in 7 models. For example, staff evaluating their progress and adjusting plans, using performance metrics and screening tools to assess quality improvement, interviewing and surveying staff, soliciting feedback from patients, or running organization-wide reflective practice or reflective groups focused on the question, how trauma-informed are we? All trauma-informed organizational change programs were funded through project grants or joint financing, and the budgets covered training and ongoing support for staff, trauma-informed practices, and changes in the physical environment. And evaluation of trauma-informed change was another domain presented across all 8 models, and organizations again use different methods to evaluate their trauma-informed transformation depending on their research evaluation capacity and funding. So the most common activities included an allocated budget, a working group or committee representing all staff groups and people with lived experience, ongoing training and support for all staff, and changes in physical spaces and clinical practices. At the individual patient level, the overall evidence showed improvement in self-confidence, safety and management of health problems, patient quality of life and chronic pain. The effect on mental health and substance use symptoms was mixed. At the care team level, we found some evidence for improvement in staff accepting attitudes and patients' perception of support, confidence in care, and empowerment. At the organization level, studies reported improvement in staff psychological readiness to provide trauma-informed care. We found some evidence suggesting change in the organizational culture through shifting staff perception of safety and being supported and valued. Patient access to services and satisfaction improved. However, the evidence for staff uptake of screening for trauma and self-care activities was conflicting. Unfortunately, no studies measured adverse events or harm, cost effectiveness, or staff health and well-being. Effects of the trauma-informed organizational change programs were moderated by contextual factors. The contextual moderators included health system values, policies, governance, business models, trauma-informed movement, organizational culture, structure, and resources. The program-related moderators included program content and format, which in some cases were difficult to implement or engage with. Our policy review analyzed 24 documents and 11 interviews with trauma-informed leads from healthcare organizations and local authorities. We found that trauma-informed approach was endorsed in national, regional, and local policies. However, there was no UK, England, or NHS-wide strategy or legislation, nor funding commitment. Trauma-informed care in the UK had piecemeal implementation, with a nationwide strategy and leadership visible in Scotland and in Wales, and more disjointed implementation in England. We identified 5 barriers to trauma-informed organizational change programs being implemented successfully in the UK. Competing demands, lack of leadership support at the organization and government levels, unsupportive organizational culture and high-pressure environments, opportunity costs and lack of collaboration and coordination across organizations and regions. Thank you for listening. I hope you found it helpful. So I wanted you to take home a message that all the research evidence for the effectiveness of trauma-informed organizational change programs is very limited. We can tell that if an organization implemented a trauma-informed approach with an allocated budget, involvement of all staff, leadership, and people with lived experience, ongoing training and support for all staff, creation of safe spaces and practices for all, research evidence showed that we can expect improvement in some psychological, behavioral, and health outcomes for some patients and staff. The second take-home message is that the implementation of trauma-informed approach in the UK needs buy-in and top-down support from organisation, NHS, and government leadership. You can find more information about findings of the TAP Care study on the study website. This is an active link on the slide, or by emailing. This is the finding acknowledgement, and time for questions. I understood there were comments in the chat or questions. I hope Angela will look and help with that.
Yeah, we can. I just want to say thank you for such a clear presentation of your findings and kind of digesting all of the work and effort that's been happening across the UK. And I suspect that the narratives in your findings are probably quite familiar to people in this space, but it is really helpful to have that wider view and to know that we're not on our own, I think, is as finding our way through this aspiration. Should I read out there are 2 questions that I've caught, so I'll start with those, and Angela, there may be others. So Liliana asked if there was any reverse mentoring of leaders, and that was at a particular point. So I don't know if you want to come in, because I think you had 2 of the questions that I was noticing.
Hello everyone. I don't know if you can you hear me?
Yeah.
Can you?
Yes.
Thank you, Natalia. A very useful discussion. I'm very, so who am I? I'm a GP in North East London. I've also held leadership roles in the Royal College of GPs in the North East London faculty. And I feel that we have to, I was very interested in that word cloud that came through, because I think it's about appreciating the system that we work in to be able to see where the opportunities are. Now, in terms of reverse mentoring, this is a concept that I'm becoming more familiar with, but it's about how people with lived experience, and this is not a focus group, this is mentoring, which is over time. And there's work in Scotland with people, substance misusers, mentoring medical students. So, Angela, I'm sure you're aware, we've discussed it in various other forums to kind of build that body of research in the medical school. So we're reaching clinicians early. But I'm more interested in a piece of work that could be submitted to something like the Health Services Journal that looks at leadership programs, because we know that we can make all these changes at a micro level, but if the leaders do not understand, I mean, I know colleagues in mental health, psychiatrists, who are just recently reading the book Bessel van der Kolk's The Body Keeps the Score, and so we cannot assume that people understand, appreciate, and I want to rather use the word appreciate the context in which we're in. So my question, Natalia, is more around, I think there's a real opportunity to get, so reverse mentoring is one, and to kind of introduce it, and then to have some sort of review of, there are loads of leadership programs all around, and I went to one, and I'll try and find it and put it in the chat, about 3 years ago. It was pre-COVID. It was run by the Faculty of Medical Leadership and Management in Scotland. I have no vested, I have no shares in that organisation. I'm not promoting them. But there was a person there who shared their lived experience, but had also formed an organisation who mentored leaders. So I can't, and this was before I had the kind of understanding and language that I have now. So I think these things are extremely powerful. So again, just to put it out there, reverse mentoring, and then some review of leadership programs, kind of just to kind of find the gap that we need to there. And Angela, if you wouldn't mind doing a screenshot of the word cloud, I would appreciate that. Thank you.
Can I just respond? My understanding is not a question, it's a reflection and suggestion. Thank you very much, Liliana. I can only respond by giving you examples from what I am aware of, what models people implemented when they did their trauma-informed transformation. Because again, if your GP practice is happy with this particular approach and has resources and willingness to use it, you are welcome to do that. I know that in one NHS mental health trust, they implement what it's called, this is the NHS-wide leadership program. It's compassionate leadership, it's called NHS compassionate leadership. It's endorsed by the NHS, and they kind of piggybacked on it and embedded it in their trauma-informed organizational transformation. So you can create something from scratch, or you can slightly tailor an existing one. In one GP practice, I was told they have a Ballantine group, which has been there forever, and they use it to use as a platform for their trauma-informed education, self-learning, whatever. In another organization, they have this reflective practice meetings where they reflect as practice. But what kind of cuts across everything, that you cannot learn it from lectures or training. It's all done through reflective learning and implementing tiny changes, reflecting and implementing, reflecting, implementing, and staying very close to your organizational needs, abilities, and preferences and your population. Lilian, I'm very interested in you because I'm currently doing a qualitative study in general practices, looking at their organizational readiness to implement a trauma-informed approach.
I'm just going to speak briefly because I want other people to come into the conversation, but I feel that I have seen over the years, I'm at the sort of opposite, I'm at the end of the arc of my professional life, but I have seen that I feel we need to, general practice is highly variable. It is now a large organization with part-time staff. There are multiple handovers that happen in general practice, and so we have to, so relational continuity of care doesn't exist, but it's possible. So there's solutions for all of this. If we frame, if we own the problem, frame the problem in a way that we can see the solutions. I think that the hotspots in the system need to be identified. And as you've been speaking, I've been thinking, I think a review of A&Es and how many have the personnel trauma transformed, and I use the word trauma transformed, work in a trauma transformed way, and because that's where patients, those are common points, and so that would be in the system because people, anyway, so you know that. And then I think leaders. So if I had a wish list and if I was spending money, leadership, A&E would be my, yes, we can trickle money into general practice is in unbelievable transformation. So I think we have to be very pragmatic. Thank you.
Thank you. I don't know if you want to come back to that, Natalia, or if we open up to other questions.
I agree with you absolutely that it should be prioritized to fit the local context and should be tailored to the organizational context, whatever the organization's abilities, preferences, and capacities and capabilities are. Yeah.
Thank you, and I guess I would add in a sort of, I don't know if it's a question or a challenge about what can we do, because I think what we're seeing is a lack of connection between the sort of national high level, this is a good thing to do, and people working on the ground trying to work in a more trauma-informed way, and what can we do as a mixture of practitioners and leaders. And this is a group, this group is very fluid in terms of who attends, but I hear your ask, Liliana, and I wonder if there's an appetite for people to think about what, for example, reverse mentoring might look like across Tower Hamlets. And I realise that not everybody's working in Tower Hamlets, but across the systems that we're working in. So if there is an interest in that, maybe we could help kind of connect people to think about what that might look like. To put that out there. Oh, yep. So get in touch. Any other questions? I think there's I can see one from Charlotte. Do you want to step in, Charlotte, and ask your question? I'll read it out. Were there any recommendations made by the TAP Care to improve future studies to increase the evidence base?
Yeah, we did recommendations for future studies. So what we found, 6 studies, this is, shocking after 20 years of this concept been around. 6 studies, unbelievable, just unbelievable. So we need robust evaluations because every study used a set of measures which they decided to use in their study. We could not meta-analyze any findings because they measure different things by different tools. there was lack of measuring organizational change, organizational culture. So it was all at the level of patients and staff, and you saw the huge gap. I mean, can you imagine nothing about staff self-care and well-being? How is that happen? That staff, the people who are supposed to deliver, was not evaluated. I mean, so the recommendations are use robust methodology, use standardized validated tools, because there are a lot of questionnaires developed for measuring organizational change. You can just take from the shelf and use, and then measure staff well-being, staff health, costs, health economics, and harms, because no one reported any adverse events or harms. There is an anecdotal evidence that some staff found training re-triggering, re-traumatizing, lack of ongoing support after training, being trained, not being able to apply this new skills, not being able to get support, can be re-traumatizing and triggering, especially for those who have their own lived experience. So these are the recommendations, methodology, and what we should measure.
Thank you. And I think I know, well, I could have a guess at the answer to my question, but do you have a sense of why not? Why aren't organisations evaluating?
So I'll tell you what we found from our interview study, because we asked this question, why. Yeah. We spent 3 months searching for anything and everything and found 6 reports. And at least the people we interviewed here in the UK, they told us, okay, we were commissioned to do this piece of trauma-informed whatever initiative. There was no money to do an evaluation. Commissioners didn't give us the money because the priority is to deliver. I have 3 projects going on. I do not have the capacity to write up anything. There is no money. So therefore, one of our recommendations to funders and commissioners, every trauma-informed initiative in the UK must have an evaluation component. We must produce our local evidence to inform our policies and practices, because at the moment, most evidence came from the US, and their system is completely different, the values are different, the attitudes are different, relationships are different. It's difficult to apply it in our context.
Yeah, I think that is interesting, the kind of it's almost like we're going to commission this because we believe it's a good thing and it will make a difference. But one of the questions I hear again and again from leaders is well, how would we know if we are trauma informed? What would be different? But then there is a kind of going the next step of, actually there are lots of measures out there that we could use. How do we apply it? And I do think it links to complexity as well as capacity, whether that's in terms of time or funding. And I think we're all working in very complex organisations and systems.
It is. You're absolutely right. There are UK developed frameworks. You can use the ready-made one. For example, there is a Roots framework, which was developed for mental health, but you don't have to use all of their domains. You can adapt it again. And this is the measure of how trauma-informed we are, where we are on the trauma-informed journey.
And we are using that in parts of ELF. And we're also using it as, I think there is a general sort of heart sink when people see how big it is. But the way that we've been using it is seeing it as this is something that can also start to carry the culture change, because it really requires teams and different parts of the systems have conversations and reflect together on where they are. And I think that by doing that, you're already starting that kind of journey towards maybe doing things differently and doing things in a more trauma-informed way. So I know it's been developed for mental health services, but I don't think it's so specialist specific that it might not lend itself to other organisations. Angela, yeah, I'm getting sort of sucked into just having a chat.
Thank you. Thanks so much for your presentation. I wondered if you would be willing to share any of the kind of off-the-shelf examples of measuring that we can distribute via this group. Obviously, it doesn't need to be a comprehensive list, but any of the kind of key ones that maybe others are using in different parts of the UK, so that we can start to help build the evidence base. I'll happily send them out to everyone.
Yeah, I'm happy to share with you. I will share with you first. It was recently issued the updated guidance from SAMHSA on how to implement a trauma-informed approach in organizations. And alongside the examples and principles, there is a section on measures, how to evaluate. There is a table with questionnaires and links. So this is from the States. I will share with you an article which summarizes system change measures as well. And are you aware of the National Trauma-Informed Community of Practice? They are hosted by NHS Futures on the NHS Futures platform. They have amazing library of resources. There is a lot there you can access. They're all free.
Thank you. I'm going to invite Claire to ask your question. I assume it's a question or comment. Please do come in, Claire.
Yeah, thank you. And really thank you for the presentation, Natalia. It was really interesting, really informative. I guess mine is a question and an observation around trauma-informed commissioning. As a voluntary sector organisation, we are very sensitive to the historic trauma associated with commissioning of community services, and how it can often lead to organisations feeling like we're scrabbling around in the dirt for the scraps that are thrown out and fighting against each other. And so I think that is something that should be, you know, as this framework suggests, it really has to be pervasive, top down, bottom up, and all in between. And something that I am a very strong advocate for, probably not surprisingly given who I work for, but I work for an LGBT mental health charity. And actually, I think there's a real need for community specific trauma-informed approaches. I think that it's not enough to just say that we have a trauma-informed approach if you're not aware of the sensitivities around what might be traumatizing for a particular group. So the same for BME communities, for disabled people, and so on and so forth. Actually, if you don't have any kind of frame of reference for systemic barriers that people have experienced, or prejudice or hatred, then that becomes really difficult to be genuinely trauma informed in supporting them. So I think that an overarching model is really useful, but it also then needs to go that step further. And I appreciate we don't even have the overarching model in place in lots of places, so that's really a big step. But I think it is something to always keep in mind and not let go of, is that actually we also need to keep pushing forward with specific details and taking that further. Is there any practice around community specific trauma informed practice?
So with the studies which we included in our systematic review, I mean, because of the population they served, for example, there were 4 general practices in Canada which implemented the same model they developed. Because they served populations with high level of Indigenous people, with high deprivation, historical trauma, alcohol and substance use problems and mental health. So how they developed this kind of community-based approach, they hired the elderly to come on board and help them to redesign services. They established connections with the local community. So they worked with the community which they served. Then their training was tailored for this population. So they did some research on prevalence of mental health and substance use in their population, and they taught this to their staff. They changed their abstinence approach for substance use to harm reduction, because they realized people drink and to take drugs not because they're bad, because this is their way of coping with the trauma they've been through. So they changed the culture, the attitude towards their patients, because they understood what's behind their health needs. The other example was an Australian clinic. They served young women in the particular populations with high deprivation. They worked with the school and police where they get referrals from. So it's just working with these local organizations and looking at who you are serving, your service. Mm-hmm. And with commissioners, I don't know, this is my reflection, and I don't know, I might be wrong, but I feel that people who make decisions about what to fund, and they have this slightly, what's the word, skewed understanding of what a trauma-informed approach is. Some of them think that if you give a 2-hour training to people, this is a trauma-informed approach. So they think this is an easy fix. And if you fund a one-off training, you can tick the box. And now the whole police force is trauma-informed because some of them attended an hour training, and now they're going to implement a screening tool for adverse childhood experiences. So I think our role and mission is to educate people who make these decisions what a trauma-informed approach is. Otherwise, it is a waste of money.
Yeah, thank you.
That is so important. I think that the kind of it's seeing training as an outcome rather than an input. You know, it's something that we need to have, but it won't do it won't do the job. I think is really important, and we have those conversations again and again. And we've also touched here on another aspect of trauma-informed commissioning, which is actually ensuring that there is sufficient capacity within the envelope, if you like, for organisations to support and care for their staff. And that is another way of ensuring that they're more likely to be able to be trauma-informed. And it's something that we keep coming back to here, and we need to kind of follow that up, I think, Angela, about how we have a conversation about what trauma-informed commissioning might look like. And I'm very mindful of the short-term commissioning, where organisations get some funding and then maybe can't carry on beyond that year or 2 years, and you have a whole population of people who use that service being maybe let down and feeling abandoned, and re-traumatizing. And one last thing that I just want to say is that we have used this space to focus on particular populations and what it means for what a trauma-informed approach means for particular populations. So I would use this opportunity as an invitation for if anybody would like to share work they're doing with their particular group. I didn't want to put you on the spot, Claire, but I can see you nodding, so I'm hoping that
yeah, I'm happy to do that. Yeah,
that would be fantastic. I think that would be incredibly helpful, and then we also might build on that to think about collaborations to bring it into, for example, for me, bring that thinking into ELFT and connecting it up with some of our other pieces of work. So hopefully this is a bit of a kind of cauldron where we're mixing lots of things up that can produce lots of helpful outcomes. Liliana.
It's been really useful reflecting as everybody's been speaking, but I think that we maybe need to think about this differently. So a meeting, the experience of a meeting can be trauma transforming. I think that I view in meetings that I've convened, we've had music. What music have we used? We've brought community voices in, and also we've used the singing for breathing work, short, 1 minute. We can have word clouds at the beginning of the meeting, at the end of the meeting. We work in the meeting in an inclusive way. So I think that there's something about rethinking this in a way that's quite creative. So the flourishing, there's a whole lot of people working on flourishing, and art and music. So music is a key thing. And so I want to say that meetings are an opportunity is all I want to say. Thank you.
Thank you. And then I'm going to give the last question or comment to, and I apologise. Is it Sherelle or Laria? So Sherelle, Laria, please come in.
Yeah, thank you so much. It was more just to kind of just say thank you. Spent a lot of time just kind of listening and thinking about people's perspectives, and you were talking towards the end about how this might apply to other populations. I'm a clinical psychologist working in the charitable sector, working for Crisis UK, national homelessness charity, and thinking a little bit about Liliana and others who have kind of spoken on the idea of, well, at least even if, I guess, you know, trauma-informed or trauma-transformed learning becomes a tick box exercise, could that at least begin to shift some things? I would say I guess it was more of a response that, you know, maybe it's more of a yes and a no, and I would say that actually there is something in, I guess from my experience, then needing to be a real kind of cultural shift as well, and this can take months and years. And I would also kind of say it'd be really important to kind of think about the motivating factors towards the training, and maybe once again just a gentle reminder that this training in and of itself, not this specifically, but trauma-informed training puts people in positions where they may become unintentionally, you know, re-traumatized in and of themselves. So it kind of makes sense that people would want to just kind of like put it in a box and be like, oh, okay, cool, did it, out the way, and engage in that unintended kind of like you know, avoidant pattern of reasoning because it's too difficult, it feels too overwhelming. But I would agree with you, Liliana. I think there's something in just being able to model, and you've just mentioned there, you know, like meetings, conversations, human voice, like there are changes that we can make. But I think the motivation behind why people want to engage in a trauma-informed environment are that's very, very important, as well as the modelling and the application to different environments. But yeah, overall, thank you so much for sharing. It's been really cool to listen to.
Thank you so much, and thank you everybody for joining us today, and particularly thank you to Natalia for sharing, which is, you know, a massive endeavour that you embarked on. Those pre-pandemic times.
Thank you very much for inviting, and I can see the area for collaboration, for kind of continuing these conversations and sharing knowledge, because these are the platforms where we learn from each other and engage in this reflective learning and reflective practice. So my understanding, Angela, we have end of session polling. And as promised, I will send Angela everything I can think of.
I have popped the link in the chat, so if you, unless you don't have it already open, you can share how your confidence is feeling now.
Do we have to kind of go into it again? Because I seem to have lost mine, or was it just the one question?
I did put the link just a couple of minutes ago in the chat again, in case people close the window. So
I had it open, but it seems to have closed itself. So
okay, maybe try refreshing.
I'll go again.
Browser. Yeah.
So, and while we're doing this, I just wanted to thank you for being so passionate and engaging. And I think, yeah, this is what we found. You know, it's all this work is driven by people like you.
On behalf of the group, thank you. I think it's good to have that feedback. While we're waiting for the mentee meter, I just want to I don't know if there may be some people who've joined us just particularly because of this topic, but I would say that you are welcome to be part of this community if that's something that you would like. In the invitation, there's a is it an MS form, MS Teams form that you can it's very brief, and if you put your details on that means you'll be on our distribution list, and we always try to let people know in advance what the focus of the session is, so we don't expect people to make a definite commitment to every session, but you are all welcome to join us on our journey going forward. And Angela, do we have a focus for the next meeting?
So the plan for the next two, so the next one is our quarterly reflective session. So that one is in September. We have them it's the second Thursday usually of every month. And then the one in October is going to focus on education settings.
Thank you. So the open session is really for us to share with each other how it feels to be passionate about this work in the systems that we work in, and sort of come together to support each other. So you are very welcome to join us next month. Okay.
I'm just resharing the slide really quickly, but it doesn't look like we've had any more responses. I'll send you screenshots after, Natalia, so that you can have it. But thanks everyone for joining today.
Thank you. So that it was just one question.
Yeah.
Okay.
Yeah.
Lovely.
And it showed shift in people's confidence, which is good for educator. Thank you very much for being such a fantastic audience. Such a pleasure.
Fantastic. Well, thank you everybody.
Thank you.
And look after yourselves, and hopefully see you in September.
Bye.
Bye bye.
Thank you. Bye bye.